So a very good morning to everyone. I, Dr. Poonam Joshi, welcome you all to our Head and Neck ACTREC academic class. Today's speaker is Dr. Narayana Subramaniam. Dr. Narayana is the head of the department and consultant in Department of Head Neck Oncology, Sankara Cancer Hospital, Bengaluru. So he will be speaking on the management of thyroid nodules. So I welcome you, Dr. Narayana. Please go ahead with your presentation.
Thank you, madam, for the invitation and the kind introduction. I'll just start sharing my slides. Are they visible?
Yes, they are visible.
Okay, so I'm going to talk about the management of thyroid nodules today. It's more of a brief overview, more of concepts than specific technical information. The idea is, how do you approach these? How do you manage them? So I'm going to be focusing more on evaluation rather than treatment. And then hopefully at the end, we'll have some time for some interactions and questions. So the outline of my talk, first, I'm going to give you a brief introduction on what thyroid nodules are. What are the etiologies we're likely to encounter when we see a patient with thyroid nodules? How do we go about radiological evaluation, pathological evaluation, and then decision-making leading to treatment? So thyroid nodules are discrete lesions that are radiologically distinct from the surrounding parenchyma. So this is an important definition. We all know what thyroid nodules are, but it's important that they're radiologically distinct. What we need to realize here is that sometimes we have clinically palpable nodules that are not distinct from the rest of the thyroid parenchyma, and these are technically not thyroid nodules. So even though we may feel, for example, nodules within a goiter, if they're not radiologically distinct, we don't treat them as nodules. So the prevalence of thyroid nodules is quite high. There have been some studies that show that when you palpate patients, you are able to find nodules in about 4% of them. But as we know, ultrasound, with the advent of high frequency ultrasound, the likelihood of picking up nodules in the thyroid gland is much higher. So almost 1 in 3 patients has a radiologically distinct nodule. But it's important to realize that only about 5% of these are actually malignant. So very often, when patients are evaluated for other problems and they undergo an ultrasound of the neck, thyroid nodules are identified, but it's important to know when to evaluate, when to investigate, and when to treat to avoid over-treating what can otherwise be left alone a lot of the time. So this is what makes appropriate management challenging. I think a lot of this also stems from the fact that patients, once they find an abnormality, when what they think is an abnormality, they want evaluation and treatment. They're scared that it could be related to cancer. And very often, as long as we follow the protocols and the guidelines and we have a sensible treatment plan in place, a lot of it is just reassuring the patient and ensuring that we don't unnecessarily overtreat, causing morbidity. So when you look at the etiology of thyroid nodules, the vast majority of them are benign. So around 80% of patients have colloid nodules, cysts, and thyroiditis. That accounts for vast majority of the thyroid nodules we encounter in clinical practice. Around 15% have benign follicular neoplasms, so adenomas and other benign follicular neoplasms. Only 5% are malignancies involving the thyroid gland. So these include everything. They include the differentiated thyroid cancers, medullary, anaplastic, and they also include metastatic cancers involving the thyroid gland. So sometimes, rarely, you can have renal cell carcinoma or breast cancers with metastasis to the thyroid gland. All of that comes within 5%. So the vast majority of patients that we see with thyroid nodules have benign disease, but of course, if you're practicing as an oncologist, that may not be representative. The majority of patients who you see may have thyroid cancer, but this is just something that we keep in mind. Now, when you see patients with thyroid nodules, a clinical evaluation is very important because that's what guides your decision making and your further evaluation. So most of the patients that we see present as painless, slow-growing anterior neck swellings. The typical description we're all aware of: move well with deglutition. When you see a patient who has rapid growth, if they have a rapid increase in the size of the thyroid nodule, it's important to think of malignancy or degenerative changes. So often you can have hemorrhage into a follicular, into a thyroid nodule. So you can have hemorrhage. These are usually painful. Uh, Malignancy is not necessarily painful. The only thyroid cancers which usually grow very quickly and then result in pain are the anaplastic ones. If there's pain, it usually indicates that there is an invasive component. So it's involved one of the structures around the thyroid gland, whether it's the larynx, esophagus, trachea, soft tissue. Those are usually the painful ones. But it's also important to keep in mind that degenerative changes can also be associated with pain, and it's not always thyroid cancer. Compressive symptoms are very important to keep in mind. These again are not specific to thyroid cancer. So if you have long-standing benign thyroid neoplasms or thyroid nodules, the patient often compensates well for them. So if you have patients with large retrosternal goiters, for example, very often they don't have any symptoms at all. They can have some vague dragging sensation or a heaviness in the neck. But if you have dysphagia or you have dyspnea, change of voice is a very important symptom, more commonly associated with thyroid cancers and other benign pathologies, usually because of involvement of the recurrent laryngeal nerve, larynx, or the trachea. So compressive symptoms are very important. They guide your management. I'll tell you when exactly we ask for cross-sectional imaging in cases of thyroid nodules. Important to keep in mind. Thyroid dysfunction, again, is very important when you're evaluating these patients. When you have hyperthyroidism, younger patients usually have the classical symptoms of hyperthyroidism. So they have the nervousness, the anxiety, the weight loss in spite of increased appetite. All of those are more classically seen in the younger age group. The older patients often have non-specific symptoms. So they can present with anorexia, they can present with atrial fibrillation. A lot of them present with congestive cardiac failure. So the presentation of hyperthyroidism can be little unusual, so harder to pick up, but very important to understand if your patient